Hi, everyone. Welcome to the How Hospitals Work with Community Partners presentation and training. It is presented by Department of Healthcare Policy and Financing, HCPF. My name is Sammy Taylor, and I am glad that you have decided to join us today. This is the second training in a series of trainings, so please visit our 4-hospital landing page on the HCPF website for details on future trainings. You can also submit suggestions on topics for future trainings or areas where you would like more resources on. Information on how to do that will be at the end of this training. We value and appreciate your feedback as you guys are on the front lines, and we want to know how best to support you with hospital discharges. So please fill that out if you have a moment. So for our purpose for the training, the department's main goal is to provide information to prevent unnecessary institutionalization into skilled nursing facilities, or SNFs, and give Health First Colorado members or Colorado Medicaid members choice in where they live and receive services. We understand that some members do want the level of care of a SNF. However, it is their right to receive an educated choice and training geared towards educating these members on their opportunities of how to remain in the community if that is something that they want. Our mission here at HCPF is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Our agenda today will be pretty quick. First, we'll review Medicaid and community partners. Our first training went into the community partners roles in more depth, so please attend that training, review it whenever you have a time if you want more information on that. And then we'll dive into hospital discharge priorities and go over some of the federal and state regulations. And then we'll talk about some of the barriers to discharge. Definitely will not be an all-inclusive list because there's so many variety, but we'll talk about the heavy hitters. And then the fourth item is roles and referrals of how to connect with community partners to help with discharge planning, and then 5 escalations, who to talk to if you're still running into barriers. So first, we're going to talk about HCBS and LTSS. HCBS is home and community-based services, and then LTSS is long-term services and support. First, let's talk about LTSS. This can be a medical and non-medical service that people who have disabilities and medical conditions will utilize in order to help them with their daily activities. LTSS services can be provided in a person's private residence, an independent living facility, assisted living, or in a skilled nursing facility. Some of the more common services that are included with LTSS are personal care to help with activities of daily living, ADLs, such as bathing and dressing. There's also in-home health care to help with any long-term or acute condition. Home modification and environmental mitigations are available, and then homemaker services, which could help tidy up the house to make sure that it's hygienic and to remove safety concerns. I do want to say for LTSS, there's actually over 60 different services. So we won't go over all of them, but there's a ton of resources. That website at the bottom of the slide will definitely go over everything LTSS related and to help you understand it if you have any questions. And then we'll focus on home and community-based services, HCBS. This is a Medicaid program that helps keep people stay safe in the community if that is what their preferred living environment is. People who qualify for HCBS have to qualify for a nursing facility level of care, and that is determined by your case manager. We won't go over the level of cares in detail, but essentially it means that this population will need to be functionally eligible for HCBS. HCBS is categorized into different waivers that people can qualify for based on their age and medical condition. Each waiver has its own set of LTSS services that the people within the waiver are eligible to receive. So EPSDT is a fun tongue twister if you say it 5 times fast, but it also stands for Early and Periodic Screening, Diagnostic, and Treatment. The EPSDT benefit provides comprehensive and preventative healthcare services for Colorado members aged 20 years and younger with administrative case management. There are no additional applications needed to access this benefit, for it is automatic for all eligible parties. It ensures that youth can receive appropriate preventative care, including dental, mental health, developmental, and some specialty services at no additional cost. All they have to do is just the normal Medicaid or Health First Colorado application. PPSDT is designed to assess and identify problems early and can provide some services such as those LTSS programs on the last slide to youth in their home to manage their health. Early is part of assessing and identifying problems early. Periodic, it refers to checking children's health at periodic age-appropriate intervals during well visit checks. The screening is providing different screenings such as physical, mental, developmental, dental, hearing, vision, and other screenings to detect potential problems at cost. Diagnostic is performing diagnostic tests to follow up with a risk as identified. And then the treatment part is managing health problems as they are found to help set a medical protocol in place. Community partners. So, like I said at the very beginning, there is another training to go over all of the community partners in depth. But I just wanted to cover really quick the community partners that we don't really talk about too often. And those are the AAAs, ADRCs, and TCAs. So let's first talk about the AAAs. Area Agency on Aging coordinates and offers services to help older adults remain in the community if that is their preference, aided by local services and supports. They help coordinate non-Medicaid services to support older Coloradans. The service can vary by region, but can include nutrition programs, health and wellness programs, transportation support, in-home services, homemaker and chore services. Some have case management, some have dental and vision assistance, elder rights advocacy, caregiver programs, and respite. They may also have life skills training, and the long-term care ombudsman can also operate out of some of these AAAs. So this is for anyone who is 6 years or older, who is needing that extra support in the community. And then for our ADRCs, our Aging and Disability Resource Centers, our ADRCs work with individuals who have disabilities and are able-bodied adults. But for those who have disabilities, they can start working with you at the age of 18, as opposed to AAAs who have to only work with those 60 years or older. So that's something to keep in mind. They provide options counseling to educate on local non-Medicaid and Medicaid services to provide support. They can assist individuals in planning for their future long-term services and supports as needed, providing options counseling, providing coordinated and streamlined access to information and assistance, and then also providing personalized and consumer-friendly assistance to empower those individuals to make those educated decisions. And then we have our TCAs, our Transition Coordination Agencies. The TCAs support Medicaid members who are experiencing barriers to discharging, and they support them to help them discharge safely back into the community. They mainly support people who are transitioning from an institutionalized setting, such as a skilled nursing facility, but on some case-by-case basis, they can support members from community to community, such as from hospital to community discharges. There are two different types of services that they can provide. The first one is Targeted Case Management Transition Coordination, TCMTC, and then the second one is Transition Services. So the TCMTC is a benefit for someone transitioning into the community who is currently approved for Medicaid. It does not have to be HCBS, it can just be Health First Colorado Medicaid. They help members determine if transition to a community-based setting is feasible, including transitioning to assisted living, independent living, a private residence, or moving in with family or friends. And they can also support with locating housing if that is a barrier to discharge. They can help coordinate the transition into the community-based setting. and they enhance and improve the members' quality of life as they do provide that administrative and logistical support during that process. And they also increase housing options for people with all types of abilities, as they do have access to specific housing vouchers that the public does not have access to. And they can also help set up those house modifications and environmental modifications within the living environment if needed. And then let's talk about transition services. So this is a benefit specifically for someone transitioning into the community who is already approved for HCBS waiver. And more specifically, the benefits of this transition services is they can provide furniture and necessary household items, including pots and pans, mattresses, beddings, or any other hygienic product or household item that may be needed. They can help have the member meet with a registered dietitian to go over any meal needs that they might have or dietary restrictions. And then they will set up a meal plan, and then they will deliver those meals to the member. They can help with assistance with managing tasks such as paying bills and balancing accounts or life skills as needed. And then also, if available in your region, they can help with peer support so the person has that social and emotional support along with the administrative and logistical support of the TCA. All right, so this is a slide of most of the community partners, just so we can see how they interact with the Medicaid member in the middle, to see how these different agencies can support the member. When working with community partners, there can be some minimal overlap. The Medicaid member works with every community partner as needed and appropriate, and each community partner is strongly encouraged to work together with all the others involved as well to ease the burden of coordination from the member. The RAE ultimately provides care coordination for the Medicaid member and will often be the liaison between the member and the other community partners, along with coordinating with hospital staff. The RAE and CMA often work together, which we'll talk about in the next section of this training, but they provide complementary services to each other where there's no overlap. Where the RAE primarily connects a member to service providers, the CMA will connect the member with Medicaid-specific services and support. The CMA and TCA both have a role of ensuring those services are set in place to allow the member to remain safe in their home. CMAs provide LTSS to the member in both a SNF setting and in the community. The TCA, however, provides LTSS and other non-Medicaid services to members in the community. One of the most common supports that a TCA can help a member with is locating appropriate housing, as they have access to housing vouchers that the general public does not have access to. TCAs work really closely with ADRCs, as the current process is that they will submit a referral to the ADRC for options counseling to see if the member would benefit more from a CMA or a TCA for support. Both the CMA and TCA can help remove other additional barriers to discharge as needed. ADRCs and AAAs can provide options counseling to provide information on Medicaid and non-Medicaid local services so that the member has educated choice. Then there is, but not least, DHS, Department of Human Services, where they oversee Health First Colorado, Colorado Medicaid, financial eligibility, and appeals. So now let's look closely into the relationship between the RAEs and the CMA. So in the middle, you will see that they both coordinate and they will help with the social, educational, and justice of other community agencies that help with that care coordination. But then RAEs specifically identify members in various ways. They also receive direct referrals from hospital staff and members themselves. Their main function is to connect members to a primary care provider, a PCP, or other necessary specialists or behavioral health providers. The RAEs are trained to not duplicate care coordination provided through LTSS and HCBS waivers from the CMA or other programs designed for special populations. Rather, the RAE shall worked to link and organize the different care coordination activities to promote a holistic approach to a member's care. The case management agency determines functional eligibility for LTSS and works with the RAE to create a service plan. The CMA does the ongoing monitoring of services, and the RAE supports the care coordination between the various providers and helps with referrals as needed. Okay, now let's look at this specifically in a hospital setting. This slide shows general scenarios of how Health First Colorado members can utilize both CMAs and RAEs during hospitalizations prior to discharge. When a member receives LTSS and needs care coordination from a RAE, the RAE would be notified by various methods from the hospital directly, either through ADT or another means. We recommend that the hospital follow their in-house policies. If the hospital staff needs to, they can also send manual referrals to RAEs as well. The RAE can also receive referrals from the member or the member's natural support directly through their individual website in their region. This is why we strongly recommend communication between the hospital staff and the member to not duplicate referrals. The RAE must work directly with the case manager and hospital staff to support discharge planning and the case manager for follow-up care. Now, on the other side of the teeter-totter, we will see a member receiving LTSS already who needs case management. The CMA continuously monitors a member while they are hospitalized and coordinates services in the person's home or community to support discharge. Currently, policy states that after 30 days of hospitalization, the member is no longer eligible for HCBS, and the CMA, the case management agency, will be notified. This policy is being adjusted due to the full implementation of the wellness education benefit will start in 2025. There will be a separate training provided on that, so please keep an eye out in our OCL newsletter for that. Until the web is fully implemented, the hospital must contact the case management agency and make a referral for re-enrollment for LTSS or HCBS to set up these services post-discharge. Hospital discharge priorities. So this will go over the rules and regulations that are coming from the federal level and the state level. So on the right side, we have those specific rules posted so you can pull them up as needed. But the quick summary of them is essentially hospitals are required to identify safe discharge plans for members that need post-discharge services and support. This includes that the member has to receive options counseling and identification of a safe discharge plan prior to discharge, meaning they have to be notified of all of their options, including institutionalization or community support as needed. A hospital discharge team is encouraged to invite guardians and unpaid natural supports of the members, such as their family or friends, and they're strongly encouraged to inform the patient of their freedom of choosing among providers and living options as available in the community. But they must be given all of the living options and not just the most convenient ones for the hospital. Effective communication with other agencies and entities throughout the hospital discharge process and the enrollment in new services and supports is required by the hospital discharge staff. They must coordinate with the case management agencies, the regional accountable entities, and those ADRCs as needed. Effective communication with members throughout the hospital discharge process and enrollment into these new services and supports is also required. So then we'll do a quick review of the Inpatient Hospital Review Program, the IHRP 2.0. There is another training on the HCPF website specifically around this amended program. So definitely check that out. But very quickly, Health First Colorado or Colorado Medicaid is required by state statute to have an inpatient hospital review program. And then the statute is listed below. The department collaborated previously with RAEs and hospitals after implementation of IHRP 2.0 to put this all together. We recognize that IHRP 2.0 dedicated other HCPF programs designed to help with hard to place, high need or high acuity patients and effective transitions of care. While we cannot abandon an inpatient hospital review program, we can tailor and enhance it to be the most use of RAISE in hospitals' time and resources. So the inpatient hospital transition, this program does involve, a process for hospitals to notify RAISE that they are requesting RAISE support and discharge planning. Please follow your hospital policy regarding this. A mechanism to share focus member-specific information with the RAISE to ensure successful and appropriate discharge planning. It also focuses on complex inpatient hospital transitions from one level of care to another. The first step is the official communication from hospitals to the RAISE while the hospitals need assistance for a member discharge or transition. The process for the RAISE is to create or request creative solutions or complex solutions depending on the patient as appropriate to assist with care coordination once the patient is in an outpatient setting, and that will not change. Barriers to discharge. So as we were talking about, this will not be all barriers to discharge, but some of the larger ticket items that often come up. So again, we just wanted to highlight transition coordination as this is a benefit of members who are already approved for Medicaid who are discharging from a hospital setting. Targeted case management transition coordination, TCMTC, is an optional benefit available to those who are currently approved for Medicaid. The benefit provides transition coordination by a TCA, Transition Coordination Agency, who wishes to transition into a community setting from an institutionalized setting. That could include transitioning to assisted living, independent living, a private residence, and/or with family. The benefit includes comprehensive assessment for transition, community risk assessment, development of a transition plan, appropriate referrals, and monitoring and follow-up activities as needed. This program has been shown to improve the members' quality of life and provides increased housing options for people with all types of abilities. One important aspect of TCMTC is that the TCA will follow the member 1 year post-transition to ensure that they are available to provide additional services as needed and available in order for the member to remain safe in the community. Then let's talk about transition services. This is a similar benefit for someone transitioning into a community from an institutionalized setting for someone who is already approved for an HCBS waiver. The member who would be eligible for all of the TCMTC benefits plus these 4 additional benefits. First is providing necessary household items such as furniture, pots and pans, or other household necessities like bedding, for example. Transition services also includes meal delivery, assistance with managing desk and peer support. At this time, TCMTC is only available to individuals who have been in the hospital for an extended period of time and the hospital discharge planner has been unable to locate any place to discharge the person to. And then we do want to note that referral to a transition coordination agency does not guarantee transition into a community-based setting if one is not available. Community to community transitions. Individuals already living in the community who have been hospitalized can still access most transition services if they're experiencing a life transition. They cannot access transition coordination, but the HCBS case manager can help community to community transitions go smoothly while existing responsibilities are in place. Examples of life transitions include, but are not limited to, the person's primary caregiver is no longer able to care for the person receiving HBS services. The person is moving to a less restrictive environment, such as from a group home or alternative care facility to his or her own apartment or into a family home. Or the person is moving out of a parent's home to live independently in their own apartment if they do have a disability, or the person has recently aged out of other Medicaid programs for children. So again, we just wanted to quickly go over different transition providers. So there is the in-reach counselor who helps individuals understand long-term services and supports and other non-Medicaid transition options. They can also connect those patients who are discharging to local community resources. Then there's transition coordinators, and they will facilitate activities to assist an individual to move to a less restrictive living arrangement for Medicaid members. And they can also, facilitate and monitor transition services as needed. Essentially, they are there to help remove barriers to allow members to transition from an institutional setting and into a less restrictive environment. And then the case manager, the CMA, determines HCBS or LTSS functional eligibility. They assess needed and monitor services as needed, conducts service referral and authorizations, and then also completes those critical incident reports. Housing. So this is a very hot topic in the state of Colorado that comes up a lot. And transition coordination agencies can provide housing support that are not available to the public with the help from Money Follows the Person, or MFP. MFP, in collaboration with local, state, and federal partners, the Department of Healthcare Policy and Finance, HCPF, will implement the new MFP demonstration to expand services and supports available to people who wish to live in the community. To be eligible for MFP, a person must reside in a Medicaid nursing facility, SNF, the Intermediate Care Facility, ICF, for individuals with intellectual disabilities, or Regional Care Center, RC, for 60 days or more with a desire to move to the community. MFP supplemental services will offer person-centered support to address social determinants of health and help members begin to acclimate to community living while they still reside in a LT or long-term care facility or a skilled nursing facility. The MFP supplemental services created under Colorado's demonstration will include environmental adaptations to provide home modifications prior to discharge, peer mentorship prior to discharge, short-term rental assistance, pre-tenancy support, and short-term food assistance. And then we also have temporary Medicaid or medical respite. In some urban areas throughout the state, there are medical respite options to help those who are stable enough to discharge but may need some oversight post-discharge to help with their medical recovery. This would mainly be for the unhoused population, but it is not inclusive to them. To help locate medical respite, you can complete a referral to your region's RAE, or you can contact agencies such as the Colorado Coalition for Homeless or Colorado Respite Coalition. Then let's talk about the coordinated entry system. And this is for anyone who wants to be reprioritized based on their condition to Section 8 vouchers throughout the state. The Balance of State BOS Continuum of Care, COC, has established a coordinated entry system. Coordinated entry is a process developed to ensure that all people experiencing a housing crisis have fair and equal access to resources and are quickly identified, assessed, referred, and connected to housing and assistance based on the person's needs. To receive these resources, the person experiencing homelessness can go through a participating agency to complete the VASPDAT, which is the Vulnerability Index Service Prioritization Decision Assistance Tool. So now we will talk about the roles, responsibilities, and referrals. So we did talk about a lot of these in the that first training regarding community partners, but I just wanted to go over this just a little bit, as some of the things are a little different for patients who are already approved for HCBS. So essentially right now, the hospital staff should complete referrals appropriately to the RAE and CMA as needed to set up LTSS or HCBS or other medical needs. And they can also complete a referral to a TCA for those community to community transitions as appropriate. And then right now, if the person has been hospitalized for 30 days, their HCBS will automatically be canceled. However, once WEB is fully implemented, the hospital discharge team or the hospital care management team should contact their case management agency to make sure that that person who may have a long-term hospitalization is set up with WEB benefits to ensure that their HCBS services do not get shut off because of the hospitalizations. So if they can be approved or set up with those web services through HCBS, then they can keep their services if their hospitalization goes past those 30 days. So that is something very key for hospital staff to know. Then again, the RAISE can process any medical, clinical, or behavioral health service referral as needed. The case manager will complete referrals to set up those services, such as the web benefit LTSS, HCBS as needed. And then the CMA, if the person is discharging into a skilled nursing facility, they have to complete PASSAR level 1 for the nursing facility if coming from the community. So just wanted to highlight that. And then HCPUB is here to support as needed. So please submit escalations so we know of any barrier that we might need to support you guys with. And then the TCA can mitigate barriers for extended hospital stay patients and provide transition coordination services as needed. And then those ADRCs and AAAs can help support with any local resources as needed once a person has discharged from the hospital. So that was for patients with HCBS. Now let's focus directly on patients who do not have HCBS. So there's only a few things that are different between all these agencies. So for patients who are discharging into a skilled nursing facility from the hospital staff will complete a PASSAR level 1 for any non-HCBS member. And they can also complete referrals to TCAs for TCMTC. The RAI will also collaborate with hospital staff to identify services and placement options. HCPUF will help as well. The CMA role does not change if the person is approved for HCBS. And then the TCA will process those referrals as needed for community transitions. And the ADRC and AAA will support as needed. So who takes the lead for some of this? The department is not prescriptive in determining which agency should be the lead in communication and or collaboration for members who have a RAI care coordinator, a CMA case manager, or a TCA transition coordinator. However, each post-discharge team should identify who makes the most sense to be the lead based on service and support needs identified. PASSAR. So the pre-admission screening and resident review program is needed for anyone who is discharging to a hospital. Discharging from a hospital to a skilled nursing facility or SNF. There are different trainings on PASSAR on the HCPUB website, so please review those if you have any questions. But this is a federal requirement to help ensure that individuals are not inappropriately placed in nursing homes for long-term care. There is a PASSAR level 1, which is just the identification screening, and that just assesses for those who might have a diagnosis of a mental illness or intellectual and or developmental disability. And then the PASSAR level 2, that is to determine whether a nursing facility settings are appropriate for those individuals if they have a confirmed mental illness or an IDD, intellectual or developmental disability. And then they will be placed in a skilled nursing facility as appropriate. So again, completing PASSAR level 1, it is completed by the CMA. If the Medicaid patient already is approved for HCBS, it's completed by hospitals if the person is a non-Medicaid discharging patient. All right, so referral. So again, we went over this in great detail during the community partner training, but I did want to highlight for the ADRC and AAAs, contact them directly or submit a referral using this JotForm link on the right, and then that will go directly to your region's local contact agency, which is comprised of your ADRC and AAA. So you can always do that. Then your case management agency, you can contact your region CMA directly. Same with your RAI, contact your RAI directly. And I did have links for those directories, so you can access them there. For your TCA, you can contact your local transition coordination agency that is operating in your county. However, you can also complete that same form, chat form on the right, that link is provided. It's the same for the EDRC and AAA, and then it'll get funneled to the TCA as needed. And then please, for HCPF, if you need any support, on the left is the hospital discharge issue reporting form. If you have specific hospital discharge gaps or barriers, and then on the right is the escalation and grievance form for anyone else, including issues with community partners. Please fill that out. HCPF support. We are definitely here to support you as needed. I will very briefly go over complex and creative solutions, as this is originated from, or sorry, it's initiated from the case management agency, but it is supported by HCPF. The creative solutions is for patients 17 years or younger, while the complex solutions is for adults 18 years or older. Essentially, this is a very collaborative meeting where the RAE and the case management agency will coordinate with HCPF to provide those extra supports as needed to help with complex discharge patients. And then contacting HCPF for support. Always fill out that escalation form as needed, or that the hospital list that was provided in the previous slide. But discharge planning has included, please contact us if discharge planning has included all appropriate referrals to agencies and they are just not participating, or they're not doing things appropriately. So that would be referrals to the RAE care coordinator, and then also your case management agency, the intake referral if HVS waiver services are potentially needed. And then please also contact HCPF for support if discharge planning efforts have not been successful and you don't know of any other options, or for lack of a better word, if the patient is stuck and does not have resources available to determine next steps. The youth and adult hospital discharge issue reporting form. So here's a link for the hospital referral form. Things that can be reported using this form include, but are not limited to, the need for supporting locally medically appropriate discharge options if the RAE and CMA support is not effective, discharge challenges due to PASSAR screenings, delayed discharge due to Medicaid approval wait times or PAR issues, or poor communication from community partners, or the need to support locating outpatient services for either behavioral health or in-home health, other LTSS services, or other resources needed for safe discharge. Contact information. So these are the team emails that you can contact for different issues, and then the escalation form is at the bottom to report any of those barriers or gaps in communication. Additional training. So everything is on the For Our Hospitals website. So please go for any additional training. There's a bunch of other trainings that we didn't have time for in these quick recordings. So please locate that if you are curious or want more information. Thank you so much. If there's anything that you want training on or resources, if you just want more brochures or printed materials available or PDFs to hand to patients, please submit this training request form. You can ask questions there, request training, or provide feedback to us. We would love to hear from you. And thank you again for taking time out of your day to watch this webinar. We really appreciate it. Thank you. Have a good day.